6:33. Wonder if we have anyone.
Okay, we're live.
Okay, let's take it away. Sister Gloria.
Good evening, everyone. Good evening, everyone. Let us
Good
pray.
evening.
Dear gracious, loving, kind Heavenly Father, we thank you so much for this very informative event that we're having this evening on kidney disease and how it affects our community. We thank you for our community partners. We thank you for our special presenters. And we pray that each and every one of us will leave here this meeting with some knowledge that we did not know before. We commit everything into your hands. In Jesus' name we pray. Amen.
Thank you, Gloria. Pamela.
Good evening, everyone. Thank you so much for joining us for this informative conversation around the importance of kidney health on behalf of the National Council of Negro Women Queens County section and our participating partners, Theta Chi Chapter of Chi Phi Sorority Incorporated, and also NACLE. It's important for us to make sure that we stay on top of our health and focus on prevention as well as intervention. And so that's one of the goals of this event is to present you with dynamic speakers who will be providing us with invaluable information to help us to be able to stay on top of our health. So we thank you for joining us this evening and look forward to engaging you throughout the presentation. And I'm Pamela Davis. I'm the co-chairperson of the Queens County Section's Health Committee. And I will now pass it over to our chairperson, Jennifer Henry, to bring greetings to everyone.
Hi. Hello, everyone. Good evening. I'm happy to see you all. Welcome, and I would like you to enjoy, participate, and take these knowledge and disseminate to others. I would like to now welcome the presidents for the partnering chapters, our own very NCNW Queens County Section, President Sakina Black.
I don't see Sakina on right now.
Is our Vice President, Deborah Wallace, on at this time? If not, we'll move to the president representing Theta Chi chapter of Chi Eta Phi Nursing Sorority Incorporated. Is Dr. Charlene Glasgow on? Is the Vice President Cherise Warner-Wallach? Is she on?
I do not see either.
We'll come back to Madam President Sakina Black and President Charlene Glasgow, or Vice President Cherise Warner-Wallach. Is the president from NACLE, or vice president, Dr. Jasmine Bratton Robinson. Are they on? Dr. Robinson, or a representative from NACLE?
I did see someone from NACLE. I will ask them to.
Kim Velez?
Yes, hi. Good
Good
evening.
evening, Kim.
Hi, let me just say yes. So I bring greetings from NACLE. We are so happy that we are able to collaborate with this wonderful event. And we bring warm greetings and hope we can collaborate in future events. So thank you so much.
Thank you, Kimberly. We'll go to the representative for Downstate Health Science University, the representative, Dr. Sarah Marshall. Dr. Marshall.
Greetings to everyone, and thank you for this opportunity. And my congratulations to Miss Jennifer Henry and her team for putting on such an outstanding event. And we know that we are going to share a lot of information, and we are grateful for the opportunity. Thank you again.
Let's backtrack to see if Sakina Black, did she enter?
No, no one else has entered.
Okay, thank you very much. So we'll just go to some ground rules that all participants can mute their phones so there won't be any distractions. And raise your virtual hands or put your questions in the chat. So we will get to you accordingly. Without further ado, we will start with our first presenter, who is Dr. Stafford John. Dr. Stafford John is a graduate of St. George's University School of Medicine. He completed his residency in internal medicine at Coney Island Hospital in Brooklyn, and he did his fellowship in nephrology at SUNY Health Science Center in Brooklyn. Dr. John serves as the medical director of the Jamaica Hillside Dialysis Center, and he is a board certified internal medicine and nephrology. Pleased to welcome Dr. John. Dr. John?
Welcome and welcome all. Today, we are going to talk again about the impact of chronic kidney disease amongst the African American community. This is an extremely important topic because, as we know, chronic kidney disease could be considered a silent killer. The majority of patients with chronic kidney disease have no symptoms. Unfortunately, the incidence of chronic kidney disease is significantly higher in the Black community as compared to the Caucasian community. And there are several factors for that. Number one, the incidence of underlying chronic diseases which contributes to chronic kidney disease is increased in the Black community. Diabetes, hypertension, diabetes and hypertension occurs at a greater rate in the Black community. But in addition, there are also other factors that contribute. Number one, there may be some genetic predisposing conditions. Number two, there are several socioeconomic factors, which would include access to healthcare, and the perception in the medical care community. But there are several factors that contribute. Now, let's look at the numbers. In the United States, approximately 1 in between 7 and 10 adults will have some form of chronic kidney disease. However, in terms of end-stage kidney disease, the incidence is almost 4 times greater in Black communities as compared to whites. Now, in terms of the predisposing conditions. The most common cause of chronic kidney disease in the United States is diabetes. And the incidence of diabetes in the Black community is about 1.4 times greater than the average population. But not only that, Black patients who develop chronic kidney disease would progress to end-stage kidney disease at a greater rate. Secondly, hypertension is, again, more common amongst the African American population. And again, patients with hypertension who develop chronic kidney disease have a greater rate or a faster rate of progression to end-stage kidney disease. Now, in terms of kidney disease itself, just a little background. As you know, the function of the kidneys in the body is basically to severalfold. Number one, the most important function, of course, is removing toxins that are produced. Every day, our cells and our tissues would produce metabolic waste, and most of these wastes are removed by filtering through the kidneys. As a result, reduction in the kidney function could lead to the accumulation of these wastes, which will have a major impact on our health. In addition, the kidneys regulate potassium, bone disease, blood counts, and acid-base disorders. So the function of the kidneys the function of our kidneys would be the kidneys will have several functions in the body. Now, in terms of detecting kidney disease, now, since we have a greater prevalence of chronic kidney disease in the African American community, one of the most important things that we need to do is early detection. And early detection will make a big difference in terms of outcomes. The easiest way to detect chronic kidney disease early will be screening. And the best way to screen for chronic kidney disease is with a basic metabolic panel blood test and a urine screen for albumin. This could be done by your healthcare provider, your physician, primary care nurse practitioner. And once chronic kidney disease has been identified, the first thing that we should do is staging. There are basically 5 stages of chronic kidney disease, which I'll keep very simple. Stage 1 is very early chronic kidney disease in which the function of the kidney is still normal, but we know either from an X-ray or a sonogram, urine test, or a kidney biopsy that some form of kidney disease is present. In other words, if you do a blood test, your kidney function test, your GFR would be perfectly normal, but there are other evidence of kidney disease. In stage 2, the kidney function is beginning to decline. However, the creatinine is still normal. And in this case, your GFR, or if you want to think of it as the percentage of your kidney function, would have declined from about 90 to about 60. However, even with this decline, the creatinine is still going to be normal. So in stage 2 kidney disease, the patients will have a normal blood test, but there is some other evidence of reduced kidney function, such as protein in the urine or a reduced eGFR. When the blood test becomes abnormal for the first time, this is stage 3 chronic kidney disease, which is divided into stage 3A and B, depending on the severity. In stage 4, the kidney function has declined to a GFR of less than 30, or the kidney function is less than 30% of original. And that is considered quite significant chronic kidney disease. At this stage, you would see complications of chronic kidney disease appearing. And that would include, number 1, the presence of uncontrolled hypertension or hypertension per se, or anemia, may start developing, and you would also start seeing problems with potassium, acid base, and to some extent, anemia. Stage 5 is when the kidney function has deteriorated to the point where renal replacement, either dialysis or transplant, becomes necessary. So that's a background. And having said that, it raises the question now as to how we can prevent the progression of chronic kidney disease. Now, over the last few years, there have been significant improvements in the management of chronic kidney disease. Some have been as a result of studies or focus studies, and others have been as a result of observation in other studies. As I said before, the first and most important thing is getting screened. Because chronic kidney disease has very little symptoms, it is important that a screening test is done early. And again, the best screening test is a basic metabolic panel and have a look at the creatinine level. A normal creatinine level is 1.0 to 1.2. For most females, about 1.0 is the upper limit of normal. And for males, especially males of African descent, it could be up to, a normal could be up to 1.2. But it is also very important to screen for albumin or protein in the urine. The presence of protein in the urine indicates early stage chronic kidney disease. As a matter of fact, protein in the urine usually appears before the creatinine becomes elevated. So screening for protein is probably the earliest method of detecting chronic kidney disease. So once you are screened, your healthcare professional would then determine whether kidney disease exists, and if so, at what stage. Now, in the United States, we probably have about 10% of the about 7% of the population will have some form of chronic kidney disease, usually stage 3. The majority of these patients do not progress, but we need to determine what are the risk factors for progression of chronic kidney disease. Number 1, uncontrolled diabetes is a major risk factor for progression. And as I said before, about half of all cases of chronic kidney disease in the United States is due to diabetes, and about 40% of end-stage kidney disease in the United States is due to diabetes. So it is very important that all diabetics should get their sugar under control. So if you're diagnosed with chronic kidney disease and you're diabetic, the most important thing is to get your A1C below 7. The second thing the second risk factor that we can modify is blood pressure. Now, hypertension, again, is extremely common, and nearly half of patients with stage 4 kidney disease will have hypertension. So hypertension is both a cause and a consequence of chronic kidney disease. You can have hypertension causing kidney disease, and you can have hypertension as a result of chronic kidney disease. Now, over the years, we have done several studies trying to determine what is the ideal blood pressure targets for hypertension. And the conclusion is as follows. If you have chronic kidney disease with protein in the urine, your target blood pressure should probably be below 125 over 75, which is lower than the target for hypertension. So anyone with chronic kidney disease and protein in the urine will have a lower blood pressure target. If there is no significant protein in urine, the target could be 130 over 80 or less. Uncontrolled hypertension is associated with a greater risk of progression. The next modifiable factor is the quantification or the amount of protein that is present in the urine. Again, the more protein that is present in the urine, the greater the risk of progression. So it is important not just to detect whether protein is present in the urine, but to measure the amount. And patients with higher levels of protein in the urine have a greater risk of progression. Now, there are strategies that your healthcare team can undertake to reduce the risk of progression, and that include medications. So there are several medications that could be used to reduce the effect or the amount of protein in the urine. What are those medications? I think this would be a good time to talk about it. Now, the first group of medications that have been shown to reduce proteinuria and stabilize the rate of decline of kidney function will be medications that we call ACE inhibitors and ARBs. So these are medications that end in PRIL and TAN, such as ramipril, lisinopril, captopril, or losartan, irbesartan, valsartan. These medications have been shown in many studies to reduce the progression of chronic kidney disease by lowering proteinuria. However, there are a couple of side effects of these medications that we should be aware of. And first, about 5% of patients will have high potassium as a result of these medications. Number two, these medications should be avoided in pregnant women because it can lead to hypoplasia or maldevelopment of the kidneys in the developing fetus. And in a small group of people, if you become dehydrated, the creatinine may inadvertently rise. There is another side effect that we all should be aware of, and that is some patients may develop a severe reaction to that. And we should be aware that some of our patients who are taking lisinopril or ramipril or fosinopril, anything that ends in PRIL, there is a small risk that you may develop a condition called angioedema, where the lips and the tongue may swell. But this is rare. But I need to put it out there so that we should know that there is a risk associated with these medications. The second group of medications that have been shown to help reduce the risk of progression are some medications called SGLT inhibitors. Now, these medications came on the market a few years ago for treating diabetes, and there are two that you probably would have heard about, Farxiga and Jardiance. So even though these medications came on the market for the management of diabetes, we quickly learned that these medications can slow down the progression of chronic kidney disease. And as a result, we strongly recommend their use unless it is contraindicated. And again, these medications do have side effects in that they can increase the risk of yeast infections, perennial infections, and phimosis in males. Lastly, thirdly, there is another medication called Kerendia. Kerendia has been shown to reduce both the development of heart and the progression of kidney disease in patients with and without diabetes. However, because Kerendia works quite similar to the ACEs and the ARBs, we tend to consider them part of the same group. And lastly, about 6 weeks ago, the FDA had finally approved Ozempic and other medications, but I think Ozempic was the one that got FDA approval for the management of chronic kidney disease. Now, we have known for quite a while that weight loss whether it was achieved by bariatric surgery or any other means, has been associated with an improvement in CKD or in renal function. So it comes as no surprise that with Ozempic use, if you could achieve more than 15% reduction in your body weight, there is an increased risk, there is a benefit in terms of slowing down the progression of chronic kidney disease. So those are the medical treatments that are available and that we advise patients to discuss with their doctors. Also, in terms of progression, the diets can play a role. Now, as you enter chronic CKD stage 4, meaning your creatinine is probably above 2 and your GFR is about 30 or less, the role of diet becomes extremely important. And at this point, we would advise our patients to reduce their intake of protein, especially red meat. Red meat intake has been shown to increase the rate of decline of chronic kidney disease. In addition, other coexisting conditions such as kidney stones, bladder infections, etc., should be treated at this point because they may contribute in some way to the progression of chronic kidney disease. Now, unfortunately, every year, about 120 or 100 to 130,000 Americans do develop end-stage kidney disease despite all interventions. And when that happens, we have options. Now, over the years, the current options as exist in the United States will be hemodialysis, peritoneal dialysis, or a kidney transplant. Now, kidney transplant remain the best options in terms of improvements in lifestyle, in terms of outcomes, survival. However, unfortunately, patients of African descent have always had lower incidence of renal transplants, and there may be several reasons for it, but we strongly encourage patients, once you have a GFR of less than 20, to make yourself eligible for a kidney transplant, access your transplant services. In New York, for example, there are about 14 to 15 kidney transplant centers in the New York metropolitan area, and we advise all our patients who have a GFR of less than 20 to get themselves considered or screened for a kidney transplant. Now, in terms of hemodialysis, there have been a couple of changes or updates that we need to talk about. At the end of the last Trump administration, there was an initiative to increase the amount of patients doing dialysis at home. And that is strongly encouraged in our population. However, because of socioeconomic factors, it is difficult or more difficult for patients of African descent to utilize home dialysis. Now, the reason why we promote home dialysis is as follows. Number one, in other words, if you are going to be on dialysis, we strongly advise doing your dialysis at home. This would involve either home hemodialysis or peritoneal dialysis, which is almost always done at home. Number one, there is a cost savings to Medicare, significant cost savings. Number two, we have better outcomes in terms of patient satisfaction, and to some extent, survival. Even though the data on survival is still questionable, but we have significant improvements in some of the markers of survival, such as heart function, etc. So we strongly advise patients to do home dialysis whenever possible. This could result in a significant improvement in, at least in terms of the measurable metrics, your quality of life at this point. And I'm sure that data will soon show that it would improve the overall survival as well. Now, in terms of the things that we can do to facilitate easy access. Number one, we need to make sure that we talk about chronic kidney disease. So we need to have communication out there in the community because, as I said before, chronic kidney disease is silent. And without communication, without talking about it, it would continue to slip under the radar. A lot of us go to the doctors, but we do not ask about our kidney functions. And in a lot of cases, we've noticed that there are a lot of patients who have chronic kidney disease, but it is never discussed by their doctors. Some patients have been going to the healthcare providers for 5-10 years, and they have stage 4 chronic kidney disease, but it was never discussed. And so we need to have an increased awareness of chronic kidney disease. We need to ask our healthcare providers as to the status of our kidneys. We also need to make sure that the members of our community have better access to healthcare. Now, there are several factors that play a role here. Now, access does not necessarily mean having healthcare insurance, but it means being able to get to a healthcare provider and being able to communicate with that healthcare provider, and also being able to implement whatever treatments that are recommended. So, for example, in our community, there are quite a lot of people who will have problems getting a prescription filled. Now, as we know nowadays, with prior authorizations and other restrictions on prescriptions, a lot of our patients get frustrated. They go to the pharmacy, the medications are not there, and they simply, oops, I'm sorry. They simply leave it at that without any follow-up. So we need to start being advocates for our family and our friends. We need to make sure that whatever access to, whether it is to getting to the doctors, getting to their procedures, getting their prescriptions filled, being able to implement any dietary plans, all of those are done. In addition, we also need to have our community ask questions. Now, I know a lot of us healthcare providers, because of the constraints under which we work, usually we have 5 or 6 patients an hour, may feel that we do not have time to educate our patients, but there are ways in which we can get around that. And that should not be an excuse. As a patient, you're a consumer of healthcare services, and you should not hesitate to ask questions. If your healthcare provider is not able or willing to answer your questions, then you can always seek alternatives. But it is extremely important that awareness be raised, because awareness is probably the most important aspect of healthcare. I think I would stop here and invite questions.
Thank you, Dr. John. That was a wealth of information. I was trying to write down some questions. but it brings back memories of school days. Pam, do we have, Dr. John has 5 minutes? Do we have anyone with questions? I will assist.
At this time, I don't see any questions in the chat. However, if anyone does have a question, feel free to raise your hand and then we can recognize you. Any questions for Dr. John?
Okay. So, Dr. John, I want to go into.
Oh, I think, okay, I do see a couple of hands going up. So let me first come to Sharice Rollock, followed by Kimberly Velez. Zoom user, if you can please identify yourself, but you'll be third. And Sharice, you can go ahead and begin with your question.
Yes, hi, good afternoon, everyone. I came on a little late, so I don't know if Dr. John discussed about the screening, the albumin, the urine albumin creatinine ratio, and the importance of doing that test for to check for kidney function.
Yes, I did mention that, and I'm glad that you reiterated that point that the screening for protein or albumin in the urine is the most important test for early detection of chronic kidney disease because the presence of abnormal protein or albumin excretion in the urine that usually precedes an elevation in the creatinine. So it is extremely important that we do that, and this is probably the most important screening test that we can do. Both from the perspective of detecting, because it will detect chronic kidney disease before the creatinine changes. And secondly, not only do we need to know whether protein or albumin is present, but the amount, because the quantity or the amount of the
Okay.
higher the degree, the higher the proteinuria. I see a hand, Kimberly Velez, I think.
Yes, hi. Thank you for the wonderful information that you're giving. I know that you touched upon that it's best to do the dialysis at home. A lot of people may be kind of fearful of that because they may not feel like they have
Yes.
enough qualifications or anything. So
Yes.
can you expand on that? That would there be proper training? So if they do have it, and just offer that resource.
Okay. Yes. Now, the way in which home dialysis works is the patients will be trained. So, for example, with home hemodialysis, the patient and another family member, preferably a spouse, would be trained or is trained. The training period lasts approximately 3 to 4 weeks. And at the end of the training period, the physician and the nurse will certify to the patient's competency. So there will be a prolonged training period. The patient would not be discharged to home without certifying their competency. And there would be a nurse that's on call that's available for troubleshooting and any issues that may arise with the home hemodialysis. With the peritoneal dialysis, again, it is the same thing. We do have a training period, again, about 2 to 4 weeks, depending on the patient's competency and the ability or the rate at which they learn the process. And again, the competency will have to be certified before the patient goes home. So yes, there will be a training program, there will be supervision, there will be support services available in case something goes wrong. And I do agree that probably the biggest hurdle is a lot of the patients feeling intimidated by doing the treatments at home. That is the biggest hurdle to home therapies. However, once the patient makes that first step to overcoming that barrier and they start training, the outcomes are usually significantly different. And once the patients start home therapies, they do not want to go back to the centers. So you hardly find patients leaving the centers and going to home therapies who are actually looking to go back to the centers.
Thank you, Dr. John. We are going to, after our next presentation, have some space for panel discussion. So I see a question or two coming up in the chat. We will not forget you. We're going to come back to those questions in the chat, but I will turn it back over to Jennifer to move the program forward. So Sister Gloria, we will be coming back to your question very shortly.
Very, very interesting. And we have such a short period of time to do all that we can do. So the next presenter will be Dr. Sarah Marshall, a professional career in healthcare, spans decades. During this time, she acquired diverse clinical experience and expertise, held in various positions in leadership role, manager, educator, and consultant. Dr. Marshall is also an independent living donor advocate. In these roles, she serves as communicator, negotiator, community advocate, and engages the media to promote healthcare issues, collaborate with the legislators to ensure that individuals and community needs are met. I welcome Dr. Sarah Marshall. Dr. Marshall?
Hello, everyone. It is
Hello.
again a great opportunity to participate in organ donation, impact and challenges affecting, I know you have Black, but I choose to say people of color communities because we are a diverse group of people. Organ donation is a global health concern, as Dr. Jones stated. This portion of the presentation is to heighten awareness about organ donation impact affecting our community and to increase donation rates and reduce the waiting list. As you know, for kidney donation now, there is a 5-year wait. And oh, I'm sorry. Yeah. Okay. Did you get my, I'm sharing my, did you get my PowerPoint? Did you get my PowerPoint? It was on before. Okay.
You have the ability to share. You can share.
Okay. So we're going to, sorry about that. I cannot advance the slides. The slide is not advancing.
Okay, I think you have to go into and put it into presentation mode.
Um,
Go to slideshow at the top.
That doesn't show on my computer.
At the very top where it says design, transitions, animations, that line across
No,
that.
that's not there. That's not there. On my top, video, participant, chat, share.
Okay,
That's what I have, those things.
lower than that. Go to the left of the name of your right. So you have you should have the presentation icon there. You have an arrow in a circle at the top, right below what you were saying.
You are screen sharing, it says, but it's not showing.
It is. It's showing your slides. So if you
Okay, advance sharing.
you're sharing now.
Okay, let's see if this is going to now advance. No, it's not advancing. I don't want to waste a lot of time. Can someone help with the advancing while I continue to talk?
We can't advance it because you're the person sharing it. So go up a little bit. Go up. Go
I'm
up.
up.
Up one, a little bit more.
Okay.
You see where you have the arrow with the circle right above your cursor is at draw.
Okay. I don't see
You see where your
those.
cursor is at draw? Do you see home, file, home, insert, draw, design?
No, that's not on this one. Maybe there is something. Shall I click OK? But I don't want to lose everyone.
Try to click OK. Now do you see your screen with the slide?
Okay. Now I see when I move that
Okay, do you see slideshow?
slide. Done.
There, yes.
I click, but it's still not moving.
Okay, so do from the beginning. Where it says from beginning, one to the left, underneath the file. It says
Okay, insert transition.
left.
I'm to the left.
A little
Insert home.
lower. Go right down where it says from beginning. Right there.
Okay.
There.
Okay. So now I'm going to advance. And I was in the introduction before I realized. So I'm up to our objectives for today. The participant, you will be able to discuss at least two chat strategies to deal with organ donation impact and challenges affecting people of color, our Black community, whatever adjective you want to describe. Describe the risk benefits of organ donation to the donor and the recipient. Explain how to become a donor. And these three outcomes address the knowledge, skills, attitudes towards organ donation and describe the role of the independent living donor advocate. This presentation is designed is descriptive, qualitative, quantitative, and the theory is living change model. And why do we need that? Because we want to change the attitude and behavior so that we will address the issue that we have in terms of the low rate of organ donors. A little background, I know you all know because you're all professionals, but I'll just say it anyway in case we have a few lay people like my husband. The removal of a healthy kidney organ and tissue from one person for transplantation into another is not a new phenomenon. However, people of color, as Dr. John said, comorbidities of hypertension and diabetes increase the risks of renal failure, is compounded by limited access, the shortage of organ donors, and longer waiting lists. For a kidney, there's an average of 5 years wait. Some individuals die before they are offered a second chance at life with a new kidney. And a day, an average of 17 to 20 people died while on the waiting list. How far have we come? In 1954, Ronald Hendrick became the world's first successful living kidney donor transplant, and he received it from his twin brother. In 1966, SUNY Downstate performed the first kidney transplant. Dr. John, you look a little too young to have been there at that particular point. Dr. Kuntz was
No.
the chairperson at that particular time. Also, the
Yes.
first
Mhm.
simultaneous kidney and pancreas transplant was performed. In 1976, computer-assisted organ, which became the United Network Organ Sharing, UNOS. In 1983, cyclosporin medication, an immune suppressant, was introduced to treat organ rejection because up to that point, a lot of rejection was creating an issue, and that's why we didn't have any kidney success. In 1984, the National Organ Transplant Act, NATO and UNOS, was passed. And the goal of this system was to ensure equity and efficient donated organ distributed based on the medical criteria. And unlike the belief that the rich and the famous or can then put themselves at the front of the line and then get a kidney ahead of someone, that's this particular act prevented that from happening. The kidney, as you can see, and as I said, I'm not berating the professionals, is being shaped, and one is on the right and one is on the left of the spine. So the benefit, it's going on its own. The benefit of organ donation, it saves lives, the lives of everyone, children and adults. The kidney removes waste from your body and helps balance the central fluid levels, filters 120 to 150 quarts of blood daily, and regulate blood pressure, keep your bones healthy, activate vitamin D, and produce red blood cells. One organ and tissue donor can save 8 lives and enhance the lives of 75 plus people. Organ donation is an altruism opportunity to help others and trust in the positive impact. While challenges include lack of knowledge, fear of institutionalized system partiality, and distrust of the healthcare providers. And that's where we are with our community, especially in light of the Tuskegee experiment, the Puerto Rican birth control, and I could go on, but I'm not going to waste that time with that because you already know many of them. Therefore, through education, transparency, and integrity, this presentation design is to eliminate the organ donation gap in the people of color communities. So we've heard it enough how that we need to build a trust because the trust is missing. The risk is that the evolution of information technology, medical research, and collaboration among interprofessionals facilitate healthcare providers' expertise and ensure high quality care intervention that prevent potential or minimize actual risk. So in other words, because of what was stated, we do not have the risk of rejection, hemorrhage, and the list goes on. Nevertheless, the distrust for the healthcare system and comorbidities were identified as the driving force for the disproportionately low rate organ donation for vulnerable population, people of color, Black. The social determinant of health for transplant include demographic, lack of knowledge about kidney donation or organ donation, social, economic, and psychosocial characteristics which fuel racial and resource disparities. Well, going. Prevention. When we look at prevention, we're going to look at trying to prevent renal failure or kidney failure. And so in order to do that, we're going to do exercise, and we should at least have 150 minutes a week, at least, any moderate exercise. We look at our dietary, we want to have balanced meal, but we want to make certain that we include dark leafy vegetables, berries, apples. We want to look at our lifestyle. Weight, we want to have the weight for the normal body structure. If we don't smoke, do not start. If we smoke, we need to stop, and we can get assistance from the healthcare facilities. Alcohol, we want to, according to the guideline, it said women should have 1 alcoholic beverage, men should have 2. I don't know about the disparity there, but that's what it says. And this come under the eradication of the comorbidities. So communication and education is crucial to understand the organ donation process, the need for outcome in order to make an informed decision about becoming an organ donor. We're going to talk about the types of donation, but before we go there, we need to communicate with our family members and talk about what it is that they desire. And perhaps we can look at changing maybe the way we approach the family from at the time, because they have been brain dead, considered to some other approach. And that would come through education. Nevertheless, we need to be aware that the team that is involved with the organ transplantation is not the team that communicate with the patient about the desire to donate a family organ. So that brings us to the types. We have the living, I'll go to the deceased, that's an organ, kidney from someone who has died or have been pronounced brain dead by 3 attendants, and therefore the organ is harvested for to be transplanted. We will talk a little more about that later. The next one is a paired donation, and that's that picture that you see shows that the incompatible match, and that would be if, say, for instance, there were 2 people who, one donor and a recipient. So say my friend Jennifer decide that she's going to donate to me, and then another colleague is going to donate to Dr. Jones. And at the same time, what happened, I'm not a match for Jennifer, and Dr. Jones is not a match for the other, but they are a match for our recipient. So therefore, that's called a switch, and they can then decide that they would donate. But sometimes there's about 3 to 4 month wait on that donation. So The living organ donation is when a family member or friend decide that they would donate their kidney to someone, and they could do that simultaneous side by side with each other. So that is, of course, the most fastest way of donating. So the cadaver donated body is a body that is donated, and that one can also be used for research. It can be used for parts of human or that's needed, but it can also be used for practice and research instead of for the medical students. So if you want to donate your body, you can donate that as well. And you do not have to pay for that particular donation, although in some cases, in some places, that was the case where there was a fee for that, and that you can arrange for that beforehand. So those are the types of organ donation. So independent living donor is part of an organ, finish that, criteria. In order for you to donate, you must be age 18 or over. A parent can give permission for a child under age. You must be physical and mentally healthy. You must be cleared by the living donor advocate. And that's myself at SUNY Downstate and my colleague Betty Jung. And there are 4 major blood types. And these types are simply noted as type A, B, and but the positive and the negative are not included in there. And I must really mention at this time is that when you get in the transplant, even though you may know exteriorly, but when you're being transplanted, you do not know what color you then are getting transplanted with. Methods of preservation from time of procurement to transplantation, we'll just stick to the kidney. It must be done within 24 to 36 hours. And yes, they must allow locally first, and then because of the electronic and the information system now, you can reach people far away. And yes, people out of the country can get transplanted here in the United States and in New York. So the independent living donor advocate is a resource specialist, and that was mandated a couple of years ago by the Center for Medicaid and Medicare and the organ procurement network as a person or team that ensures protection of the living donor and prospective donors, maintain donor confidentiality. These roles fall within the domain of nurses practicing at the full extent of their education and expertise. Further lead to disintegration of disparities and systematic biases and promote an increase to organ donation. That brings me to myth and facts. Challenges that discourage organ donation, such as some may feel if I go on the list, what's going to happen is that they're going to take my kidney without my permission. Or if I'm having an emergency and I need care, they will not give me the care I need. They will then decide that they take my kidney instead. No, that does not happen. As I stated earlier, you must then provide all the care that is necessary. And then you must then be pronounced brain dead by at least 2 independent attendants, not any on that team. There is no age limit. Religion, there's only a few religion that has objection because they feel that the body must go back the way it came into the world. Health. Some severe infections such as viral meningitis, active tuberculosis, and mad cow, you are not able. At one point, it used to be that you were not able to donate if you had cancer or if you, if you had cancer or AIDS. But it's currently they feel that a person who has AIDS or has cancer, they can donate to someone who also does have AIDS or cancer. Therefore, the intent to increase organ donation ensures demystification would be to integrate into the student's curriculum and newly hired employees' orientation, organize and implement public health promotions. And Ms. Henry, that's where you're going to come in also, and Kimberly with that. Community outreach programs, workshops, schools, faith-based and civic organization to disseminate the information at all system levels. I know it may seem like something, but it's feasible and it can be done. Education. The initiative program process starts with education. Participant engage in an icebreaker, and I know Kimberly is great for her different types of icebreakers. Then complete the pre and post 5-point multiple choice Lincoln questionnaire survey, which we have already, but time does not permit us to do that. The collected data is then analyzed by the living donor advocate or a designated committee to determine appropriate strategies to promote organ donation. Information and the social media may be used to facilitate this process and include all populations because our diverse families and communities. Further, more individual will become a donor through the motor vehicle department or by completing a donor form on the Donate Life America website. Therefore, expected result from this educational program initiative will be an increased awareness about organ donor process, the transformation among interprofessionals, and the public's attitude and behavior will lead to a significant decrease in the wait list, which is 90,000 at this particular point, and mortality. So in conclusion, the federal regulatory agency mandate that individual living donor advocate must be a registered professional nurse. And this role falls within the domain of nurses practicing at the full extent of their education and expertise. Further, lead to disintegration of the disparity and systematic biases and promote an increase in organ donors and therefore decrease that gap in our community whereby there is such a high rate of people that might need but do not have because of the limitation and the access and the availability. Thank you. I will entertain questions at this time.
Thank you, Dr. Marshall. At this time, we'll just take 1 second to introduce to our program our NCNW Queens County section, Sakina Black, to recognize President Black. We'll go to NACLE Vice President, Dr. Jasmine Bratton Robinson, for recognition. Dr. Robinson.
Hi, good evening, everyone. Um, I'm so happy to be here and listen to this very informative presentation. I'm learning a lot. I'm the representative from NACLE, the Nurses Association of the Counties of Long Island. Thank you for inviting me here. Thank you for inviting members of the organization. And I'm happy to be here, and I hope that NACLE and this organization continue to collaborate to bring information to members in the community and members of the community and other health professionals. And thank you so much, everyone.
You're most welcome, Dr. Robinson. Uh, President Black, are you available to recognize yourself at this time? If not, we'll go into discussion. I know we have a wealth of questions. Pamela will go to the chat and we will entertain questions at this time. Then we will recognize Madam President sometimes before we end.
Yes, thank you, Madam Chair. So we do have one question in the chat from Gloria Winley, and the question is, what symptoms in my body would cause concern for kidney disease?
Unfortunately, most forms of kidney disease would be asymptomatic. However, whenever there is pain or discomfort in the area of the kidneys, it is usually due to a stone or an infection, which may or may not be related or progress to chronic kidney disease. However, as the kidney function begins to decline, some of the symptoms will be excessive tiredness, loss of appetite, loss of weight, nausea, vomiting, and unexplained anemia, the recent development or worsening of hypertension. So those are some of the symptoms that may be associated with chronic kidney disease. However, if you have progressed if you are at the point where there is loss of appetite, loss of weight, severe anemia, I think the kidney disease has probably advanced too far. It is most likely irreversible, and you're at the stage where preparation for dialysis or transplant is needed. So in the early stages, there are basically no symptoms that are attributable to chronic kidney disease.
Thank you, Dr. John. I don't see any other questions in the chat at this time, but does anyone else have a question they would like to ask of either of our panelists? If you can just raise your hand and then we can recognize you. Let's scroll through here. Any other questions? I'll come to Sharice Rollock and then to Jennifer Henry and then to Kimberly Velez in that order. Sharice?
Yes, hi. So either Dr. John or Dr. Marshall could answer this question. There is a protein is called alpha lipoprotein, which it says is very common in African Americans, and it can be related to kidney disease. Is that something that is screened, especially for organ donation, like for kidney donation?
Alpha lipoprotein has been associated um, with cardiovascular risk. However, there is another protein which we call APOL1 that this is well, there is a genetic product or gene, APOL1 gene, that has been shown to increase the risk of developing chronic kidney disease if two abnormal copies of the gene are inherited. We do know that this gene is common in people of African descent, and it does play a role in the increased risk of CKD in the African American community. Now, about 5 to 7% of the Black population will have two abnormal copies of the gene. And if you do have two abnormal copies of the gene, it will not necessarily cause kidney disease, but it increases the risk of having damage to the kidneys by any method except diabetes. So if you have two abnormal copies of the gene and you have lupus, HIV, hypertension, it everything except diabetes, the risk will be increased. And the same thing happens with, we had noticed that the longevity of a kidney transplant from an African donor was somewhat less than that of the white donors. And as a result, for many years, we felt that kidneys from African donors were substandard. However, in recent studies, once we're able to identify those patients with two APOL negative genes, sorry, two APOL positive genes, if those patients are removed from the donor pool, then the outcomes are the same. So as a result, we are now screening for APOL1 genes in both donors and recipient, especially in donors of African American ancestry. So most transplant centers are now screening for APOL1 genes amongst the donor pool.
Okay, yes. I think, yeah, I had the wrong APO, I
That's
had the
okay.
wrong protein. Yes, yes. So I was just wondering if it was something that is definitely being screened, for those who are donating. Just thank
Yes,
you for that.
yes, it is
Yes, thank
something
you.
that yes. So for many years, we have always for many years we have actually when I was at Downstate, um, I remember in Morning Report, Dr. Eli Friedman said had asked, I think there were about seven of us, and he asked, why do you think that our Black lupus patients have worse outcomes than the whites? And everyone felt that it was because of noncompliance. But at that time, we did not know that there was a genetic cause. But Dr. Friedman, in his wisdom, said, look, I know my patients, and I can tell you it is not noncompliance, and it is not the socioeconomic factors. He realized that there was another factor, which at the time was not identified. But about, I think, in about of advances that were made in Vanderbilt University, we quickly realized that there was a genetic component. Now, in terms of how much this APOL1 gene contributes to the worst outcomes, it's difficult to say, but it's probably less than diabetes and hypertension. So it probably ranks third in terms of the increased risk that we see in the African American community.
I guess it's my turn to ask the question.
Yes,
Dr.
Mr.
John, could you quickly, I know you might have touched on it earlier in your presentation, acute kidney injury.
Okay. Yes. Now, acute kidney injury is different from chronic kidney disease, and that's a very important distinction to make. When we talk about chronic kidney disease, we're talking about a reduction in the kidney function or in the GFR that occurs slowly over a period of at least 3 months. However, acute kidney injury describes a sudden and rapid decline in the kidney function as a result of an acute injury. Um, the most common cause is shock. So acute kidney injury tends to occur in hospitals. So it is usually seen in hospitals. And as a matter of fact, about 1 in 10 patients that are admitted to a hospital will have some form of acute kidney injury. And if you go to the ICU, it probably will be seen in about 1 in 5 patients. Now, acute kidney injury basically describes a rapid decline in the kidney function as a result of an insult or injury that is caused usually by shock, infections, or sometimes medications or therapeutic agents that we use to treat and diagnose our patients. Unlike chronic kidney disease, about 80% of acute kidney injury usually recovers. However, acute kidney injury may increase the risk of chronic kidney disease. In other words, about 20% of patients who had acute kidney injury will have a reduced GFR about when they're checked about 3 to 6 months later. So acute kidney injury is a risk factor for developing chronic kidney disease, but that's the distinction. The acute occurs usually within hours, and it is usually reversible, and it is as a result of either injury from medications, radiographic contrast, but by far the most common cause is septic shock, septic or cardiogenic shock. Anything that reduces the oxygen delivery to the kidneys will cause acute kidney injury.
Thank you, Dr. John. Let's take two last questions. So next we're coming to Kimberly Velez and then to Jasmine Bratton for the last two questions.
Okay, so this question I have is for Dr. Marshall. And the question is, I know that you mentioned the different types, but can you name the different types of the transplant? I know that there's a living transplant, but what are the other names for the other ones, and how many are there? Are there 3, 2? Thank you.
There are two main types, but there are the two main types, but there are 4 actual types. So you have the deceased organ donor, and that's from a deceased person. You have the living donor. You have the switch. Let's see. It's the paired kidney paired donation. And you have the cadaver. The cadaver is the body, the entire body, and the paired is when you have 2 individuals that are incompatible, because when you are being screened as a donor, you get a comprehensive medical follow-up, which include the blood, scans, and history. And so you have all of that. So when you have the blood work done, the blood work may come back that you are incompatible for the person that the recipient that you are donating to. But there may be someone else, not necessarily in this state, but could even be in another country, which has happened at SUNY Downstate, whereby they do have a match. So therefore, that would be a switch. So say, for instance, at that time I stated, and I had it on the slide, whereby the red indicated that those 2 candidates, for lack of another word, were not compatible. But one of the candidates was compatible for another, And therefore, that was the switch in terms of how they were able to then still donate and still have their family or friend get the kidney. And that is guaranteed. No one can say, I will do that, and then later back out and say, I'm not going to do it. Because in that case, the donation usually take place before you're actually having the transplant. Did that answer your question?
Oh, can I add something? Now, I think we should also, oh, pretty soon, we probably would be adding xenotransplants to the list. And you probably heard in the news recently that there have been several trials of pig transplants. I think we had two in New York at NYU, and one had taken place somewhere in the South. I don't remember. However, I think maybe in the next probably 5 years, xenotransplants may become a real thing. What actually happens is that the pigs are genetically modified, and the genes that can induce rejections are bred out. So these pigs are modified to remove or to delete the genes that can trigger a rejection. And so far, the progress in the last 20 years have been tremendous. So I'm certain that, well, I cannot be certain, but maybe in the next 5 years, we might be doing xenotransplants. So that may be something that might be added to the list in probably 4 or 5 years. We'll wait and see.
Thank you
Thank
both.
you, Dr. Joe. Kimberly, did that answer your question?
Yes, I see Kimberly in the chat.
Yes, I couldn't unmute. Yes, thank you, Dr. Marshall.
Okay, so Jasmine, we're coming to you now.
Hi, good evening. Thank you so much, Dr. Marshall and Dr. John, for sharing your wisdom, your knowledge related to this topic, very important topic affecting the African American community. So my question is, there's a great emphasis that's always placed on the social determinants of health. And this question is for both Dr. John and Dr. Marshall. So with all the emphasis placed on the social determinants of health, do you find that sometimes there's a bypass of looking at genetic factors and other factors that can be looked at? Or do you think there's equal emphasis on the social factors and genetic factors, or sometimes this thing gets overlooked?
Okay, in terms of I think we are still overlooking a lot of socioeconomic factors. Unfortunately, biases still exist in our healthcare. These biases may be implicit, or or it may not be. But unfortunately, it does. Now, social factors, and we have to remember, or we have to look at a couple of things. And that is, even if you have equal, quote unquote, access to healthcare, the outcomes are not the same. And a good example is looking at the Veterans Association, the VA. So when you look at the VA, now the VA does not have any discriminatory policies in terms of providing access to care based on race. However, if you look at the VA's outcomes, there is definitely a difference in outcomes between Caucasians and African Americans. And it is not access because the VA has open access to everyone. So there are other things that are probably that we overlook that is contributing. And those are some of the things that we need to look at. So I think that we that there are a lot of social and socioeconomic factors that we miss that play a role, and I think it continues to play a major role, even more than genetic factors.
Thank you.
That's a great question. And most definitely, there is a lot of biases. And basically, what I recommend is that we all first look at our own biases because we do have biases. And even though the military, as you stated, Dr. Joan, does not have any kind of bias policy, remember, it's the people that are working there, and they all have biases. So therefore, you then will find that because if you look at where you live and where you work, and I find that a lot of times people then, even now, when they're doing social determinant of health for patients that are coming into the facility to try and accommodate them, the patients are not comfortable. And those who are taking the information, what they're doing is they're not very fair with the information that they are providing. So we need to really look at first the healthcare providers and their biases. And yes, they probably will still have some. But we definitely need to make certain that we look at them because it may not indicate it as a policy, but it may be done as a practice and also as individuals.
Thank you. Thank you for your responses.
Thank you both, Dr. Marshall and Dr. John, and thank you everybody for those great questions asked of our presenters this evening. I'm now going to turn it over to Madam Chair Jennifer Henry to close us out, as well as Madam President Sakina Black. Thanks everybody once again.
Thank you.
I want to thank everyone for coming. I also want to give recognition to Theta Chi chapter, Chi Eta Phi sorority. A moment of recognition is Dr. Charlene Glasgow on, or maybe Sharice Ronan-Raleigh would like to give a moment of recognition before we go to NCNW, Madam President.
Hello, hi. So, yes, this is Sharice Warner-Rawlock. I am the Vice President for Theta Chi chapter of Chi Eta Phi professional nursing sorority. So I just want to thank both Dr. John and Dr. Marshall for an excellent presentation this afternoon. March being Kidney Awareness Month, this is very appropriate. And unfortunately, we are living in a world where everyone have their biases, but the African American population has many challenges to combat to keep themselves healthy and to thrive in this society. So I just want to thank both of you again for all of the valued information that you provided this evening. Once again, thank you.
You're welcome. So before we go, I just want to thank everybody once again and thank all the participating partners and affiliates. And we are empowered to go out and educate our communities for healthier and better lives. Madam President?
Thank you.
Good evening, everyone. Sorry I was a little late. I was coming in from another event, so I got in a little late. But certainly, I thank you so very much, Dr. John and Dr. Marshall, for the wealth of information you shared with us today. Um, Invaluable. We are so in need of this information for our community. And so I also thank Theta Chi chapter again for partnering with us. And of course, our chair of the health committee, Jennifer Henry, and Pamela Davis, our co-chair. You ladies are always right, spot on. You do a great job getting this together. This is Kidney Month, as you say, so it's very, very important that people recognize this. I'm sorry we didn't get more people, but each time we give it, we have different people on, and hopefully the word will continue to get out there about the importance of this information and people managing their awareness of the disease and therefore the disease itself, particularly in our communities, because people take it for granted that they don't have it. They don't know that much about it, so they're not clear about what they should do. So this will help them learn more about what they should do, what they should look for, get screened, etc. So we really appreciate it. Thank you so much taking your time again on this Sunday evening, which is a day of most people are just relaxing. So we really appreciate everything that was done today. And thanks for all the participants. So gracious. So have a good evening. And I turn it back to Jennifer. You're muted.
Sorry, this is where we end the event. I'm not sure if we can take a picture, screenshot rather, sorry. Nicole, our communications media person. Thank you. There we go. Let us know when you're ready and you're done.
It's done, and I'd also like to just advise everyone that this recording will also be on the NCNW Queens County section YouTube